I'd like to now introduce Tracy. I'm sure a lot of people here know Tracy Worrall. She's the Chief Executive of QPAS, that's the Queensland Program of Assistance to Survivors of Torture and Trauma. And she's worked in the community sector for many years, in fact over 30 years, and that has included direct service delivery and working in disability services. And as she says, her current role allows her to mix her passion for social justice, her interest in refugee and asylum seeker issues, and her interest in community-based organisations. She's been in her role at QPAS since 2007, and today she'll focus on psychosocial disability and coal communities and the NDIS. Please welcome Tracy. Just press that like that. Oh, there we go. Just press that one down.
Okay, hi everybody. I think a few people know me, and I certainly know quite a number of people in the room. The first thing I'd like to do is acknowledge the traditional owners of the land and their elders past and present. But I'd also like to acknowledge that there's a lot of expertise in this room, both from communities with which we work and also from NGOs working in this space. So I don't want to actually even pretend that I'm an expert, particularly in this area. I just want to have a conversation about some of the things that we're finding, and we would be open to having that conversation after this. I guess I also feel I need to say something about today. I think it's fantastic and I think it's great, and I'm really happy and would like to thank Amparo and Griffith for inviting me. However, I am very disappointed that the NDIA rep came and spoke to us and then left. And so, in fact, I actually think that needs to be noted and passed on to them, because one of my frustrations with the NDIS is I've been to a lot of meetings where we've tried to communicate to the NDIA about what we're finding, but the NDIA want to tell us what they think and they're not listening to what we're saying. And I think this is another example of where the NDIA has come along and given us some information, and some of that was great information, but then went without listening to what people are saying. So I'd just like to say that. So I'm going to see if I can actually work this machine. Okay, so I'm from the Queensland Program of Assistance to Survivors of Torture and Trauma. I actually labelled this afternoon's presentation, and I'm going to try and be quite quick because I know we're running over time, NDIS, mental health, cultural diversity and the disconnect. Because one of the things that I've been asked to talk about is how the NDIS may work with people who within the mental health area and within the culturally diverse area. And early there was talks about silos. So we have cultural diversity, we have mental health, and we have disability, and we have the NDIS. And we're actually really struggling getting that connect between those silos. So first of all, who is QPAS? So we're an NGO, that's because I'm saying the NDIS. So we're a statewide NGO in Queensland. We're a very specialised service. We work with refugee survivors of torture and trauma. So that's people who've experienced torture and trauma prior to arrival in Australia. And that includes people who are here now on permanent visas, but it also includes working with people who are asylum seekers or people in the future who will only have temporary visas. We're a recovery-based service, and we work with individuals, we work with children, adults, teenagers, young people. We work with families, and we do a lot of work with communities. And a lot of our work is focused on working with communities around how we can best meet the needs of those communities. Each year in Queensland, we work with approximately 2,000 clients, individual clients, from over 70 different cultural groups. We're one of 8 services across Australia that form a FAST network, so people from other states. There is one of our services in those states. In Victoria, that's called Foundation House. In New South Wales, that Starts. And together we work with about 15,000 people a year across Australia from about 200 different language and ethnic groups. We have about 70 staff in Queensland from about 35 different ethnic groups, so that's our own staffing pool. We're predominantly funded out of the federal government. We do receive a very small amount of Queensland government funding as well. We're the Queensland member of FAST. We have no intention of being an NDIS provider, so I want to say that up front. We're not actually wanting to move into this space, but we want to make sure that the people we work with can access their needs and get support under the NDIS, and that's the whole reason that we've stepped into this space, is to try and do that, not to actually look at how we can provide services in the space. So, in theory, this is probably, I'm not particularly positive about the NDIS. I need to put that up front. At the moment, the experiences that are being recounted to me and the experiences that we're having with the NDIS are not particularly positive. That's not to say that I don't think that there's a whole range of things that can be done better, that people with a disability, whatever that disability is, hasn't got the right to a better access of services and a higher control and level of independence. However, the experience that we're having at the moment is that the NDIS is not necessarily providing that, certainly for the people we work with. So, for example, I would say the NDIS is in theory, committed to a cold strategy. It's not been finalised. We're a number of years down the track and it's still not been finalised. Other areas have had their strategies finalised. I've got no idea whether it includes anything on mental health because we haven't seen it. So that's a bit about the disconnect. I'm sure it's got some strategies around culturally and linguistically diverse, but whether it has any strategies about the connect in with mental health, I don't know. I think the lack of consideration of cold issues and mental health means that the NDIS has been shaped in isolation of those factors. So I guess one of the things I think we need to have a conversation is about how we address that. Some of the things that I'm going to talk about have already been discussed. So as we've already discussed, the trial sites have reported a 4% take-up rate of approved plans of people from COL backgrounds. In the NDIS, and this is an example for me about some of the confusion that exists within the NDIA and the NDIS, is the state with the highest take-up rate for people from culturally diverse backgrounds is the Northern Territory. Its rate, depending on which report you look at, is between 65 and 85% in the Barkly Tablelands. I used to work in remote Northern Territory, and I know that in the Barkly Tablelands there are a lot of people who don't speak English, but they're not actually from overseas born or culturally diverse backgrounds. They're from Aboriginal and Torres Strait Islander backgrounds, and so mixing of the data is not helpful. And so again, I think that's something that needs to be fleshed out. Only 7% of people with approved plans nationally have got a psychosocial disability. To date in Queensland, that's translated to 2.5% from a COL background and only 1.6% of participants with a psychosocial disability. Would like to acknowledge very early days in Queensland, but not looking good. So for me, there are issues that can be categorised into three areas, and some of those I'm going to go through quite quickly because I think we've really covered them a lot. So one of them is general mental health. That is issues associated with people who have a psychosocial disability who will need to access the NDIS for supports. They're not necessarily just about people from culturally diverse background, but it might be exacerbated for people from culturally diverse background. Then there's general culturally diverse background issues, which are across all aspects for people who are accessing from different backgrounds, but may be exacerbated for people who have got a psychosocial disability. And then there's ones where those two connect. So I'm going to just go through some of those quite quickly. We've got limited time, but some of the things that we're seeing for general mental health issues are things like the concept of permanency within a recovery framework. This is, for us, exacerbated when we're talking about survivors of torture and trauma, because the whole basis of recovery is grounded in the fact that people are having abnormal experiences, people are having normal reactions to abnormal experiences. So that is that they are reacting to things that have been in their lives and that they've experienced, but their reactions are relatively normal. They may, in fact, be having mental health consequences of those experiences, but the engine room, if you like, of some of the mental health issues is the torture and trauma that's been experienced. So that's a really critical point for us. Stigma. We've talked a lot about stigma today. Stigma is a very broad issue, and it's difficult enough when we're working with communities. But when you're working with communities for whom mental health issues are not discussed or acknowledged, and the treatment of people with mental health issues historically has been very poor or not even provided, it's a real problem. Concept of early intervention at this stage is driven by a disability frame. In fact, you need to have accessed the NDIS before the age of 7. Most of our people aren't even in the country before the age of 7, the people that we work with, but under a mental health frame, the age of 7 is not early intervention. The need for a diagnosis. The need for a diagnosis is very problematic, and in fact, Megan, you covered it earlier, that in fact, for a lot of people in our communities and in mental health, you'll need to have the most severe diagnosis that you can get in order to get maximised support. That's a really negative thing to do in the mental health space. GP preparedness around mental health, and whether or not either it or the NDIS is able to cope with the concept of trauma as an engine room for some of that. GPs are quite difficult in terms of access for some of our clients. They cost a lot. Specialists even more so. There's long waiting lists. A specialist appointment for a psychiatrist in the private sector in Queensland is a gap fee of about $150. That's a gap fee. So if you need to go along to a psychiatrist so that you can get a diagnosis in order to access support, that's a real barrier. LAC knowledge and understanding in relation to mental health, and in particular in relation to trauma. I know that there's quite a lot of talk about education for LACs around how they gain cultural competency, but a lot of LACs are coming into the program having worked in disability services, but may never have worked in the area of psychosocial disability. How do we have LACs trained around both? The concept of mental health as a disability. That's a real difficulty for the mental health sector, and I know there's a few people here from the mental health sector. It's not a term that's generally used in the mental health sector. General cold issues, and this has been talked about a lot again today. Cold populations are not homogeneous, and there are enormous differences between populations, both from a health and a mental health perspective, but also from an access perspective. And in particular, I just want to note a few of those for us. So new and emerging communities versus established communities. New and emerging communities have a whole range of different issues when it comes to accessing services than communities that have been here for 2 or 3 generations. And some of that actually is around frameworks. So that's around frameworks and understandings around what health is, how health, bad health, ill health occurs, and that's got to be discussed with those communities. Populations who come from similar health frameworks versus those who come from very different frameworks, and some of those are very different cultural frameworks as well. So people who come from collectivist communities versus people who come from much more individualistic communities. This is a scheme which is about an individual entitlement. Now, if you have a collectivist community approach, it's very difficult to understand an individual entitlement system, and in fact there's limited capacity to roll those out, and people get quite frustrated about them. Questions of things like, what's going to make a difference in your life? Now, if you've come from long-term displacement or refugee camps, what makes a difference in your life may not be anywhere near the sort of things that an NDI scheme is expecting to hear, and I might come back to that a little bit under language. Use of language, again, from an individual or community aspect. From a terminology perspective, so that's concepts that are being used by the NDIA, and that was alluded to earlier by Steph in terms of concepts around disability, but it's far greater than that. Try telling someone what an insurance scheme is. You know, people go, I haven't got insurance. And you go, well, that's actually not, you don't actually have to have insurance to access the NDIS. What does insurance mean? But things, a whole range of concepts. What is a good life is a very cultural concept. What's going to make your life more fulfilling? Well, perhaps a visa for a family reunion process. So I'm waiting for the NDIS to come back with an answer to that question, because I know that for a lot of people we work with, if you ask them what would make the biggest difference to their life, it would be family reunion. And in fact, the NDIS is not going to give them that. So there's a whole range of different issues around language that we need to overcome. So then another one is the preparedness of the NDIA and LACs to use interpreters, and we talked about that earlier. And I can't believe that after 30 years we're still talking about access to interpreters. And I find it so depressing that we're still talking about access to interpreters. But one of the key things for us is it's not just about accessing an interpreter, it's actually about accessing the right interpreter, or an interpreter who's appropriate. So we can't just train people to ring an interpreter. You've actually got to ring one who might be the right gender, who might be from the right ethnicity, who might actually have the right dialect. It's not always just as easy. For us, we work in mental health. It may also be about having someone who is going to be trusted by that community member. So it might in fact be someone from a different ethnic group. The concept of a consumer and a carer. That's a really interesting one in our communities, and sometimes they're all the same. So people may be a carer, they may be a consumer, they may be a community member, they may also be the health professional within that concept. So it's actually a continuum. Access to interpreters at the service delivery level, it's all great having them for the plan. If you can't have it at service delivery level, it's a problem. Access interpreters for GPs and medical specialists. We know so many clients who go along to the GPs, go along to mental health services and have no access to interpreters. We still have people presenting at hospitals who get assessed for suicidality without an interpreter. Access to information and promotional strategies designed specifically for this target group. None of these are new. So where does this intersect lie? And that's the issue for us. So the first one for me is we work with a whole lot of people who are not going to be eligible for the NDIS, and in fact who are going to be put out into no access to services land. So if you don't have a permanent visa, if you haven't come through the offshore humanitarian program and get a permanent visa, you're actually not going to be eligible for the NDIS. So people we work with who are asylum seekers, not going to have access to the NDIS. People that we work with who have been found to be refugees but came via boat are only going to get temporary visas. People on temporary visas in Australia, despite the fact they may be here for 20 or 30 years, are not going to have access. They don't meet the eligibility criteria under the NDIS. What happens to those people? Who's going to support those people if they need the types of support? So that's a really big one for us. The automatic right, this is an interesting one for us. As I said, we work with people who've come from a range of different experiences, but common in their history is they've experienced high levels of trauma and complex trauma, or they've been tortured, or both. And the automatic right of the NDIA to access client information, or to access any information and to collect information, is highly problematic for our groups. There's a trust issue about who you give information to and why, and what that information might be used for. Remembering that these people have had things like information used against them. And I shouldn't say these people, that's a terrible term, but people who come from refugee backgrounds. Assistance and advocacy to access the NDIS, we've talked about that. The fact that some people need 50 hours of unfunded, that's really good when someone can access some settlement support. But if they're outside of settlement, that is, they've been here for too long to access settlement services, who provides that level of support for them to access the scheme? Assessment processes without the building of a relationship based on trust. So one of the things that's really important for some of the client groups we work with is the capacity to build a relationship and build a trusting relationship. They're not going to go along to an assessment with someone they've never met from a service they've never heard of and tell them about some of the things that have happened in their lives. And that needs to happen at the individual, the family and the community level. LAC knowledge of the refugee experience, and for us, the impact of trauma on people's experiences is really critical to how people continue to operate in their lives. The concept of early intervention, I talked about, access to GPs and the individual entitlement. Self-management of packages, which is something that is being promoted by the NDIA. But if you come from a context of unfamiliarity with Australian expectations around employment, around how you manage other people, where does that sit and how is that going to be managed? And they're just some of the issues that we're seeing, amongst many. So is our message being heard? I'd have to say at this stage I don't feel it is. There's been, I think, some general success around the more general disability area in intersection with COLD. But I think there is a very low level of interest in addressing these issues, particularly around that intersection between mental health and culturally and linguistically diverse communities. And in fact, when I talk to the people who are responsible under NDIS around mental health, they say go and talk to the culturally diverse team, and when I talk to that team, they say go and talk to the mental health team. So there's actually a very strong lack of interest about how those two things work. And I would say there's very limited buy-in around some of the things that might make a difference. So what might we do to create a culturally safe and responsive system? I think the first thing that the NDIA has to do is recognise that different communities have different understandings and different needs, and we've mentioned this a lot today. Different conversations may need to be held for different communities, for different individuals, and that actually needs to be funded. So the capacity to go and talk to individuals, to go and talk to groups and to have a conversation needs to be funded. And it needs to not just be funded around what the NDIS is, but from our perspective, what is mental health and how does that fit with the NDIS? Because for a number of the communities we work with, we have to actually still have that conversation around what mental health is. Trust needs to be built, or alternative processes need to be designed, and that's particularly important for survivors of torture and trauma. For us, families need to be part of any planning processes. It's not about an individual. For many of the people we work with, they work and exist and live within families. That's no different to anyone in the community, but it needs to be acknowledged and it needs to be taken into account. We need to ensure people from new and emerging communities have access to support and to advocates. There must be a system of individual and independent advocacy, and it must be funded. There needs to be dedicated ILCs and LAC capacity in order to have some understandings of these different systems. For us, the issue of confidentiality and access to information has to be addressed. When we're working with a number of clients, they will withdraw support and withdraw permission with our agency to work with them if we have to get them to sign a form that says we'll hand their information over to any government agency. And for some of the people we work with, the fear of that information being handed over to the Department of Immigration and impacting on a visa status is huge. And so one of the critical issues for us is how is that going to be handled in the NDIS? And at this stage, it's just we need to access everyone's information so we can have a better case. That's a problem. And the language used needs to be rethought, not the interpreters, that of course needs to be rethought, but the language and how things are explained, described, I can't even use a website. I don't know how anyone I work with can use it. So I just want to, I guess, finish up by saying this is a quote I have on my whiteboard, because I don't want to say that things are all not changeable and that we can't get something positive out of it. But I guess my quote is, diversity plus complexity always leads to innovation. And so if we can make the most of our diversity, take on board the complexity, we'll end up with better services. But we actually have to be able to do that. And if the point of the NDIS is to enable a system to respond to individual needs, and the system has to be flexible enough to do this, otherwise we'll just have different winners and losers. So thank you.
Thank you, Tracy, for that. And I'm sure that a lot of us here would share a lot of your frustrations and really understand what you're talking about, particularly in relation to silos and the very complex situations that a lot of people that you're working with and we're working with them face. I was just thinking, Tracy, maybe if you don't mind having questions after Maureen, because I think that really what Maureen talks about in the launch of the report follows on from a lot of the issues you've raised. And I'd just also like to just point out that we do have NDIA representatives. There is a stall at the back of the room, and I'm sure if anyone's got questions, they'd be willing to answer them. So although Steph has had to leave for the day, we do have reps from NDIA here. So, and I'm sure they're listening and learning.